Welcome to Mastering and Guideline in Ultrasound and Echo. Hi everyone. In this lecture, I'm not going to talk about the anatomy and mitral regurgitation. You can go check these clips and lecture in the channel. If you look at the history and literature, we can see mitral valve prolapse during the history and past has different name and a lot, completely a wide spectrum of the presentation and pathology and physiopathology aspect of the mitral valve prolapse. For that reason, some experts they call it and defined mitral valve prolapse as a wide spectral, from one side as a myxomatous degenerative and other side as fibroelastic deficiency. But nowadays they prefer, there are more evidences that show mitral valve prolapse actually has a different entity, that each of them are different. Based on the histopathology and echocardiographic or imaging feature and surgical aspect, now we can divide it phenotype in three categories: myxomatous or myxomatous degeneration, fibroelastic deficiency, and those related to the connective tissue and syndrome like Marfan syndrome and so on. And another topic and issue that has been recently take more attention is arrhythmic mitral valve prolapse. That is one of the most common cause of the sudden death among the patient with mitral valve prolapse. And I'm going to talk about these three topics: myxomatous degeneration, fibroelastic deficiency, and arrhythmogenic mitral valve prolapse. Now let's look at those two major phenotypes of the mitral valve prolapse. Myxomatous degeneration or Barlow disease, usually it happens and involve the patient at average age 20 to 40 years old. They are young and they have longer history of the symptom that we talk later. But in the fibroelastic deficiency, average age is 60 years old, above 50. And in both of them, it has been found some genetic marker that they are different in each of those. And in Barlow disease, the positive history of mitral valve prolapse in family is about 25% compared to the 5% in the fibroelastic deficiency. In Barlow disease, usually both leaflet is involved. They are thickened and elongated, puffy shape, and you can see in both leaflets usually. And another finding in Barlow disease is that mitral valve annulus dilated, and it play a role in the mitral valve annulus disjunction that later I am going to talk about. That finding that is very important, especially it will be a risk factor for the arrhythmogenic mitral valve prolapse. In fibroelastic deficiency, usually one segment involved, most of the time scallop P2, but any of those scallop can be involved. And in other part of the mitral valve leaflet usually is thin, and some of those chordotendon especially are fragile and teeny, and they are very susceptible to the rupture. That again, it's dependent of the severity of those disorder, means lack of the connective tissue inside of the fibrosa, in the here at the level of the left ventricle side, and spongiosa, or even at the level of the atrial. Those are decreased because of lack of production or deficiency production of the connective tissue, including collagen, elastin, and proteoglycan. That usually it happens with aging and senile degeneration. You can see here at the fibroelastic deficiency usually is P2 involved and one segment usually, but in the Barlow disease usually not only thickening and elongated of the mitral valve is both leaflet involved. Beside of the histopathology changes in the mitral valve leaflet and mitral valve annulus, another factor that play a role for the mitral valve prolapse is the mechanism of the mitral valve annulus contraction during systole. As you can see on this normal, during diastole and early systole and late systole is more to the lateral and more pulling to the commissure, but in the fibroelastic deficiency and myxomatous disease or Barlow disease is different from the normal and from each other. And beside of that, in some patients, the insertion of the papillary muscle, especially posteromedial, and length of those leaflet and all those changes that happen in the apparatus of the mitral valve, especially in the basal inferolateral segment that later I'm going to talk. Each of them play a role in creating mitral valve prolapse clinical feature and findings. About 2 to 3% of the population has mitral valve prolapse, and mitral valve prolapse is the most common cause of the mitral regurgitation. Most of the patients with mitral valve prolapse, they are asymptomatic, and depending of the severity of the disorder, especially mitral regurgitation, and how long the patient has mitral valve prolapse, the symptom can be vary, and it can be from the just palpitation, dizziness, or goes a little higher, exertional dyspnea during activity, reduced activity level, chest pain, dizziness, and in advanced stage heart failure, and in a specific group of the patient we can expect to have sudden cardiac death. That is not common. Later we are going to talk about that. Gold standard for tools for diagnosis and evaluation of the mitral valve prolapse is echocardiography. Before that, let's explain some terms. As you know, anterior mitral valve leaflet is longer than posterior mitral valve leaflet, and the point that they contact each other during systole we call coaptation. In normal situation, the coaptation is anterior to the mitral valve annulus. How we find mitral valve annulus? We go find the hinge to hinge anterior and posterior mitral valve leaflet hinge. Where is the hinge? Hinge the spot that mitral valve leaflet move around that spot. At the anterior, you can see at the insertion of the aortic valve, and next to that is the hinge, anterior hinge and posterior, you can see with the ciner loop go back and forth, you can see exactly which spot posterior mitral valve leaflet connected to the atrioventricular junction or annulus. So if during systole we make it a marker connected from that anterior hinge to the posterior hinge, that will be our annular plane of the mitral valve. In the normal, this coaptation is anterior to the annular plane. In the mitral valve prolapse, one or two part of the mitral valve leaflet goes beyond the annulus plane to the left atrium. That it can be bilateral or bileaflet, as you can see here. Here we have annular plane. Both of them, anterior and posterior, goes beyond the plane. The diagnosis windows is plaques or parasternal lung access or apical three-chamber if we have good image, correct view. And the diagnosis when is the bulging is equal or more than 2 millimeter. So we go back and forth at the systole largest bulging. At that moment, we go measure the amount of the bulging. Here you can see, and shortly in the next slide, I am showing you more accurate and better images. Another type of the variant of coaptation we called it Prodormal Carrier. In those cases, the coaptation is central or anterior because the posterior mitral valve leaflet become longer, and so we have coaptation central or anterior. Those type of the cases are susceptible to developing mitral valve prolapse. Beside of the bulging and detecting the amount of the bulging prolapse, we can see other finding based on the type of the mitral valve prolapse. For example, in the Barlow disease, we can see thickening of the mitral valve leaflet and elongation or long leaflet, depending which one. Most of the time both of them, but sometimes only one of the leaflet is elongated, thickening of mitral valve leaflet, and all secondary finding related to the mitral regurgitation. Most of the patient with mitral valve prolapse has mild mitral regurgitation, and less than 10% they have a severe mitral regurgitation that most of the time are with the flyel or rupture one of those chordotendini mitral valve leaflet. And the consequence of the mitral regurgitation, we can see it like left atrial enlargement, left ventricular enlargement, and so on. Here we have all different type of the mitral valve prolapse, normal coaptation anterior to the mitral annulus plane. Here, when this red spot is a coaptation point. When the bulging is less than 2 millimeter, we call it ballooning. Here we have posterior mitral valve leaflet bulging more than 2 millimeter. Here leaflets mitral valve prolapse, both of them bulging. Coaptation is still untouched, so those tip of those leaflet kiss and contact with each other. In flyel mitral valve leaflet, the flyel leaflet tip of that goes beyond the coaptation and is floating inside of the left atrium. And if you put color over that, we will see significant mitral regurgitation that dependent of the, if it's anterior, we have jet central or posterior. If it's posterior flyel, usually we have central or anterior jet. Here we have a posterior mitral valve leaflet prolapse. As you can see here, not only the patient has MVP, there is a perforation in the posterior mitral valve leaflet that you can see on the apical 4. We have two jets, one at the level of coaptation, exactly that spot, and another here that is perforated mitral valve leaflet. Because the type of the fibroelastic degenerative deficiency, it become thin and they are susceptible to the perforation, but it's not common. In M mode, we can confirm the prolapse too. The most important part for that purpose is that make sure our cursor pass through to the spot that bulging to the left atrium. In that case, we can see very easy which leaflet is bulging and has prolapse. For example, on this case, you can see posterior mitral valve leaflet during systole move posterior, or on this case you can see both of them move posterior, so we have bilateral or bileaflets MVP. Here we have just only posterior moving. It is as almost at the correct center and separate, and you can see how much we have prolapse, or here the same, and so on. The incidence of the sudden cardiac death or cardiac arrest among of the mitral valve prolapse patient is less than 1%. And among those patients, the mechanism of that, most of the time they think that is ventricular arrhythmia, ventricular tachycardia, or ventricular fibrillation. And the mechanism for that, they think that the combination of the autonomic nervous system, especially sympathomimetic sensitivity increased, and another is fibrosis at the papillary muscle, especially posteromedial and at the basal of the posterolateral or infralateral or lateral of the left ventricle. Among those patients that are in high risk for this type of the mitral valve prolapse, that we called it malignant or arrhythmic mitral valve prolapse, are those patients that has bileaflet prolapse, those that have the sign and marker for ventricular fibrosis, especially in cardiac magnetic resonance imaging, CMRI, or they have ST and T wave abnormality, biphasic or reverse, or T inverted in the inferior leads 2, 3, and AVF, or the patient that has complex ventricular premature ventricular contraction, because a simple is very common in the patient with mitral valve prolapse, but those that they have polymorphic PVC, they are in the high risk for the malignant mitral valve prolapse. And the next one is mitral annulus disjunction, and finally those with the high S prime in the tissue Doppler TDI. Now let's go see what is the disjunction and what about the high S prime in tissue Doppler. In normal situation, mitral valve annulus junction and insertion connected to the basal of the left ventricle, and they move together toward the apex during systolic phase. But whenever this insertion separate from the left ventricle base, we called it disjunction if it's more than 1 millimeter. As you can see here, in this case, this amount of the displacement of insertion of mitral valve annulus is very obvious. In one study, it has shown that in those patients with mitral valve prolapse, a disjunction more than 8.5 millimeter can predict non-sustained ventricular arrhythmia with a sensitivity of 67 and a specificity of the 83%. And it showed that it correlates with the fibrosis in the left ventricular, especially basal and papillary muscle, posterior-medial papillary muscle. And they are in high risk for the developing malignant MVP. Another parameter that shows it is positive in a patient with susceptible to the malignant mitral valve prolapse is high velocity of the annulus in tissue Doppler. For that we called it a Pickelhop sign, and for that purpose we go do tissue Doppler on the annulus, on the mitral valve annulus at the posterior annulus, anterior in apical 2, and lateral annulus and on apical 4 chamber. If the S prime become equal or more than 16 centimeter per second, it is a positive predictive value, and it showed that the risk of the ventricular arrhythmia in those patients with positive Pickelhop sign will be 3 times to the compared to those patients that doesn't have this spike S prime. Management of the mitral valve prolapse will be in another lecture. Up to the next time. Have a wonderful time.